start?
Yeah.
Cardiac condition.
Yes, cardiac condition start. Okay, so you dispatched to a 50-year-old male complaining of substernal chest pain. Hurts right here. Presented with an onset of about 15 minutes. You were called, you and your crew. What kind of stuff you want to know?
You have shortness of breath.
Yes.
Do you have nausea?
Nausea. Why would you go straight for full safety?
Because I want to rule out the worst case scenario.
Oh, it is not full safety.
Has this happened before?
So, skin?
Very, very pale, diaphoretic, clammy.
Has this happened before?
Never.
Anything make it
So-
better or worse?
No.
So after that,
Does it really need
after looking at general impression of sick with pale, cool, and extremely diaphoretic, I want to get him on the monitor first. You put on the quick pads to get a quick look.
Quick add.
Get the pads on instead of a four lead. Yeah, the pads instead of the four leads. They get a look through the pads at what the rhythm
I'll
is.
give you a hint. We just go with the 4 leads first. Like it's very rare unless somebody's unresponsive. Do we put the pads on first? Like we get our whole picture kind of thing. So we get our 4 lead, and anytime we get a 4 lead, we get a what? 12 lead, right? So that's part of our initial vital signs now.
Can you get the same as a four lead through the pads?
You can get 1 lead and only 1 lead. Okay, so you get lead 2, that's the only lead that you get with the pads. So basically that gives you a rate, and that's about as good as it is, unless of course it's V-fib, V-tac, something like that that you can shock right away. Okay? All right, so pale, cool, diaphoretic, dizzy when I stand up, very, very, looks sick, you say. All right, so you're getting the four lead on. 4 lead, you're getting on. Vital signs are 70/30, heart rate of 120, and it's weak and thready.
So we're transporting.
No, we're not transporting. That's the worst idea ever.
What's SpO2?
Because we're not going to do diesel therapy, right, Dustin?
Not always, not first, not at
Not first. We get our pictures first, right? I don't want to go. Fine. You want to transport? I don't want to go. Now
You know
what?
what, let's keep working at it.
in the ambulance.
What's his
Fine, RSI the guy.
Good, smart. Okay.
Respiratory rate, SpO2?
SpO2, respiratory rate is 14, and O2 sat are 92%.
What's his heart sounds?
Heart sounds.
Oh.
It's almost like you guys read, like you're supposed to read things. Heart sounds, I don't know, what would you expect to hear with heart sounds?
Are they muffled?
How would you know what muffled heart sounds sound like?
Because we practice
All of
really
our
well.
fellow student hearts.
You guys are listening to each other hard?
Yeah, why not?
Have you found somebody with a muffled heart? Yeah.
Hopefully not.
It's Mons. Okay. Heart tones are
No heart.
non-muffled. Man.
But we.
Well, while we're at the heart tones, what were the lungs?
The lungs.
Lung sounds, because we're
Lung sounds
listening.
slightly diminished in the lower. Diminished lower. Clear upper.
How about the result of the 4 lead?
Result of the 4 lead, so your initial pulse said 120, you actually hook up the monitor and it's closer to 150.
How much does our patient weigh?
And it is sinus tack.
Okay, so this is going to be
150.
symptomatic,
Cardio.
unstable, fast, no drugs, electricity.
Are allergic to electricity?
Does he have medical history?
Did you say, are they allergic to electricity?
No? Okay, let's shock.
So, here we go. So this is where things start to become tricky for you guys. You guys are starting to get just enough knowledge to make you guys dangerous. Okay?
We were dangerous before.
You were dangerous before, but now you guys are getting really dangerous. Now you guys have the ability with electricity, right? And drugs. Like so you have all the drugs with half the knowledge that you need for those
Yeah,
drugs,
right.
okay? So sinus tack. Anytime you can differentiate that it's a sinus tack, is that something that there is a chemical issue going on that needs to be interrupted with medication, or is there a something that has to be interrupted via electricity? Or is the sinus rhythm acting normal? Is the SA node working normal?
sinus rhythm is fast.
Okay.
It's what's going on with the sinus rhythm that causes the problem.
So, okay. So, we have a sinus tach, right? So that's fast, tachy, fast, right? So we just have a fast rhythm. We have a fast rhythm with a decrease in blood pressure.
Narrow, fast, regular.
That's hypotension.
That would be-
We are pale pulmonary.
They're not pulmonary or anything, are
Slowly
they?
unstable.
Is the QRS wider than narrow?
If it's sinus tach, it's narrow.
It's sinus.
You can still have wide, complex sinus tach, you can still end up with wide. Based on if somebody overdoses on different types of medications, it can widen out your QRS interval. But, no, good question.
What's
It
their
is narrow.
abdomen like?
Abdomen.
Yeah.
Like rigidity?
So, did you guys forget I have this chest pain that I've been telling you guys about?
Aspirin?
Just to remind you, hey, my chest hurts really bad, just to let you know. I just wanna let you guys know that. And you guys went straight to, oh, hey, I know what we're going over today, blah, blah, blah. It's like, so I'm just like, oh.
Can you take a full, can you take a deep breath?
Are you
Can I
taking
take a
any
deep breath?
medication?
Are you able to take a deep breath?
It's not very comfortable.
Right, it hurts, but are you able to?
Yeah, I can take a deep breath.
Does his
Mm.
blood
Are you
pressure
taking any
drop?
medication?
Yeah, I am taking medication.
What are you taking?
I take Coumadin and metoprolol, and I just got done taking antibiotic. I don't remember the name of it. And then I take what else did I take? There's some other drug I take that's for my blood pressure stuff.
What
Do you
were
have
the
pedal
antibiotics
edema?
for?
Are you normally high or low blood pressure?
I'm normally high.
Right, because it's on beta blocker. What about your feet?
My blood pressure change upon inspiration. I don't know. Let's see. How would I figure that out?
Hold your breath while I take it.
Shit.
Do you notice anything? Why don't you come on up here, Amanda? Come on up. Come on up.
What about your feet? Any pedal edema?
Stand by.
Here's where we're.
Oh, no, this is good because you guys are all gonna start getting picked on, not picked on, but called on. All right, so you want to check. So what is it you're checking now?
If his pulse is changed upon inspiration.
My pulse is changed upon inspiration. Okay. So like, what do you mean? Like speed? Like strength? Like one weaker than the other? Like. All right, go ahead and check whatever it is you think you need to.
You're not gonna have radial pulses with the blood pressure, so you
That's true.
Do you notice any pedal edema?
I do not have any pedal edema.
Wait,
Why
wait,
were you-
wait, do your thing, yo.
Why?
Okay, so when I check the carotid artery,
Can you find a brachial?
Check for moral.
when,
You can watch your EKG if you're looking for a rate change.
So I am as white as the wall right now.
Of course you are.
That's okay.
You were that way when we came in because you're sick.
No, I'm not sick anymore. I just got
Maybe fluid.
But you're white as the wall.
Blood pressure is low.
Right now I am.
okay.
Yeah.
Right now you
Why
are.
were you
I
taking
just I'm getting
antibiotics?
worse. Antibiotics. I got a small little infection going on.
What was that infection?
I kind of just had this sore on my leg.
Can we see that sore on your leg?
Why do you want to see the sore on my leg?
Because I want to see if it got better
It's
or
all
worse.
better. It's all better.
It's all better.
Yeah.
Was it MRSA?
I don't know what MRSA
We
is.
don't give a crap, he's going into shock.
I was on IV.
Can we get it?
So, looking over your body, my eyes are looking for anything that's not normal. I'm checking you out from head to toe.
Oh, man.
Looking for anything that doesn't look like it fits on your body. Like, do I see bulges, infection, like,
You see a fistula in venous.
Uh-oh, we're dropping. Can we?
First sign is that he's dropping.
So we're definitely behind now.
Supplementation.
yeah, so,
Have we got my IV yet? Let's get some.
Nope.
IV.
Why can't you get an IV on me?
because you have no blood pressure.
Okay. So
You need to lay
you guys.
down.
Oh, you want me to lay down?
Yeah. Why are you walking around?
Because you guys aren't helping me.
Can we
I'm
try
getting ready to
it?
call 911 again.
All right,
Call somebody that knows what they're doing.
I want to get the pads on
I
you.
like,
Yeah, can we give you aspirin and have you do vagal maneuvers while we're getting other stuff?
But he's-
Vagal maneuvers if his blood
So-
pressure keeps dropping.
So when you guys become clueless on what to do, right? What did I tell you guys to do?
Just do something.
Just do something.
Do something, okay, good, yes.
That's what we're trying.
Before I told you to do something, what tools did I give you to make sure you did before you did anything? What are you supposed to do before you do anything?
Did a history.
Go back through your history.
Okay?
Go back to basics.
And so what are the things that I talked to you guys about, like, when you get stumped, always keep something in reserve to be able to ask?
Oh, the sample questions.
Oh, got some sample questions, what else, what other kind of questions? Did I mention I have chest pain?
Yeah, and
How long-
does it radiate anywhere? We put a lot of them except for radiate.
Yeah, it radiates.
Can you
It
describe?
radiates into my back and left shoulder.
On scale of 1 to what is
Pause.
it?
It's a 10.
Take control of this patient, shut everybody, shut up, let one person ask questions.
No.
There's too much stuff going on.
I think we're all just like,
Come on.
oh, man.
He's having an aneurysm.
What do we do? I'm dying,
Is he?
right here,
Was he
right
having an
now.
aneurysm? It's already blood.
Can you get a monitor for me? Can you go get the airway bag? Can you get the trauma bag?
Oh jeez, trauma, oh, now I'm dying.
I know, where I
I'm
got
dying.
Can you go and start an IV for me? We can get this going. So, full sample history, our ABCs we've got, to a certain degree.
To a certain degree, okay?
Alright, what don't we have for our ABCs? We've got our blood pressure. Are you diabetic at all?
No, no.
Okay, so for right now, I'm gonna rule out the CBG at this point. We've got our lung sounds. Lung sounds are diminished on the lower at this point. Internal CO2,
It's 35.
35. So at
Probably.
this point, we don't necessarily need getting oxygen on board. Sample history. Give me one question.
Do you have any heart problems?
I have high blood
Yes.
pressure.
He has high blood pressure.
I've had a couple of heart
You
attacks.
had a couple heart attacks.
You had stents put in?
Aspirin.
Nope,
Do you have any,
stents.
are
Are
you
you allergic
allergic
to
to aspirin?
aspirin?
I'm not allergic to aspirin, but my doctor told me not to take it because I take Coumadin.
Okay.
So what do you take the Coumadin for?
I occasionally have an irregular heartbeat, but it's controlled.
Do you know what
I had
that,
a little TIA when I was younger.
do you know what that irregular heart rate, what they called that irregular heartbeat, or just call it irregular?
They just call it irregular.
Okay.
Yeah, it's an occasional thing, it doesn't happen very often.
Chandler, can we get our 12 lead hooked up?
Totally sinus tack.
12 lead sinus stack?
It's a 160. Sorry.
I don't know if you guys asked this, but can you describe your pain?
It hurts.
Yeah.
Does
I
it
figured that.
feel like pressure?
It hurts right here.
Right here, and then in regards
So
Yeah, we did.
pericarditis? So did you just have an infection?
Bad infection of those.
Is it sharp or stabbing pain? Neither one of those? Can you describe the pain for me?
There's nothing you can do if it's a triple.
It looks like somebody just taking a knife and just starting at the top.
Ripping the pain down.
Great, great.
Radiating in the lower back.
Can we please transport it?
Yeah, it's like, can we transport him?
Can we give it
Who does not want to give aspirin?
We do not want to give aspirin.
Give me a reason.
Because we're thinking a tear.
Just give me the reason. Don't just say no.
Because it's a bleed, active bleed.
You are
Okay.
going to bleed.
Fine, fantastic.
Not do this.
We want to get you going.
So,
Not once.
everybody jumped on it. So, how quick could you guys have come up with AAA had you guys gone through the normal steps of patient assessment?
Probably quicker than we did.
Everybody remember what AAA stands for?
Aortic, abdominal aortic aneurysm.
Abdominal aortic aneurysm, okay?
But they're not always,
They're not always abdominal.
they're not always
They're always
pulsating.
So, like I said, remember how I told you guys I'm the master of scenarios? So what was the very first question you guys asked? Is it pulsating? So what do I automatically do?
No way.
No, it's not pulsating. Had you guys not asked that question for a while, then yes, it was going to be pulsating. But what it does is it makes it so that you have to know what the event is, right? Ask those OPQRC, ask those sample histories. Had you guys simply just gone down the normal conversation, discussion of a patient history, you guys would have picked up on it much, much quicker, okay? So,
How so?
Hold on.
Because we could have gotten tearing versus crushing.
you guys would have got to your OPQRST, and based on the OPQRST, based on the severity, the type of pain is the thing that as soon as, because he's like, is it a sharp pain or is it like a heavy pain? And I'm like, nope. I'm like, what is it? It's like, well, it's like this knife coming from here to here, and then he's like, oh, it's like a tearing. I'm like, yeah. So what do we automatically jump to when we hear tearing pain?
Aneurysm.
Aneurysm, right? So we automatically are be like, boom, red flags go up, boom. So as soon as you had the pulsating, did you guys immediately kind of just be like, oh, it's not a AAA and head down another path?
Everybody but Annalise, because she's a rock star.
She hung on to it.
Well, I have a question about that. You talked about flash pulmonary edema a while ago, and you talked about reducing your questions to rule out your most severe scenario, and how you're supposed to get hands-on really quick. I don't have to ask you if it's pulsating. I can palpate it,
Sure.
and if I didn't have it,
Then I wouldn't have given you a pulsating mask.
then that's okay. So I just wonder, why is it detrimental to leave to your OPQRST questions that are going to rule out your worst-case scenario?
It's not, that's what I'm saying, is you guys never got to it. That was the problem that happened there, was you guys never made it to the OPQRST. You hit one or two of them, and then you guys went on this wild goose chase of listening to all the other history I was giving you, and I had to remind you how many times I got this pain here.
Right.
Hello, are you going to do something about it? Like, you guys didn't go down the chest pain protocol. You guys didn't go down any sort of pain protocol of what was going on. Like, you were trying to figure out, like, I got 1,000 different questions. Everybody has 1,000 different thoughts on what was going on. Whereas if you simply stick with get your whole picture, sample, hey, you walk through, yeah, this guy's sick. Okay, let's figure out why. Worst case scenario, is there a pulsating mask? No? Okay. Is that the end of AAA?
No.
No. So you have to, so it's one of those things you're like, okay, I'm gonna move it to here, but I'm not getting rid of it. I'm still hanging on to it, right? Because there are things in that history of what type of pain is it? Does it radiate? Does it move? Does it change? The problem you guys had is I heard a lot of questions based around like cardiac tamponade and some PE question type stuff. And that's all because that's all stuff that you guys read, and you guys are all trying to be on the spot and be like, oh, I'm gonna get this right because we just went over this and this is what we're covering today. But nobody really focused on our top to bottom assessment, get the picture, get all our questions, and then be like, okay, I've asked all my questions and I still don't have a clear thing. What am I missing? And what do we do when we're missing something?
Go back again.
We go back and we rethink, and we reevaluate, and we make sure, all right, did we miss something here? Okay? So, discussing aspirin. Do we give aspirin to a AAA?
No.
Absolutely not, right? So is this person, so with the aneurysm, let me pull this up. I got pictures I got multiple, so.
Last rites of the family.
Not yet, getting close. Have I popped, yes or no?
No.
Why have I not popped?
They're still present.
Because I'm alive still, right? Can they have a slow leak?
Why
Yes.
We're gonna bleed out in like 3 heartbeats.
is that why your blood pressure's so low?
Yes. So let me show you.
So if your blood pressure's that low, would you have a distended, rigid abdomen?
It all depends on where it's at. It depends on where the aneurysm is.
And where it's
So-
bleeding out?
Oh, you were so close, Amanda. I was so excited. That's why I brought you up. You're like, I want to know about your pulses. You're like, oh, I'm going to grab your pulses. I'm like, yes, please do. Because with AAAs, what type of presentation do we have in regards to pulses? What potential could happen?
Very different on both sides.
Is everything always up here in a AAA? No. Can pain from a lower aneurysm radiate in the chest,
Yes.
radiate up here? Yes?
The symptoms are going to be similar to our cardiac symptoms,
So remember when somebody says, hey,
right?
check a femoral pulse, right? Jump right on top of that. That is perfect, because what that can tell you,
Oh, so you weren't joking, Smith?
he
Of course
was
not.
joking. He was joking. but he
When
had
do
no
I
idea-
ever joke?
He had no idea that he was like, I'm like, ooh, we may actually get this. Like, I'm thinking, all right, we're heading in the right direction. I know they have no idea why they're asking this right now, but. So, if you have a potential femoral aneurysm or even an abdominal aneurysm, you will have unequal pulses. You'll have one leg that has no pulse whatsoever. You'll have another one that has pretty much a bulging mass of a femoral artery because all the blood is being directed into one location. Okay, so let me pull some pictures up for you here real quick.
So even with the BP being that low, I'd still be able to feel a femoral pulse?
Mm-hmm. Especially because all of the blood is being pooled into one location.
Okay.
I don't know what kind of pulse.
So you were saying about
What's the minimum for femoral pulse?
what you're asking
Probably a
about.
little higher than maybe
85%
60
of them
here,
do.
80 here.
I'd say lower.
Sorry, so 70 maybe?
Right, I'm just saying, if we have an aneurysm in that thoracic cavity,
Because it's bigger.
if we have it above the diaphragm, does that mean that that blood's gonna leak out in the thoracic cavity and then we would have
Took us a while.
something similar to
Like your legs.
tension pneumo?
Inside the leg.
Alright, so,
Oh, man.
here's a couple pictures of some aneurysm locations. Let me see. Alright, so, you can see here, a giant aneurysm down here. So this has the potential so that it can work its way down the femoral artery, and boom, that's where you end up getting your unequal pulses on one side versus the other. Right?
Are
It's a very
you saying
common-
that aneurysm's gonna travel?
No, it has the,
Oh.
so this has the potential, this whole thing is not gonna move.
Right.
This thing can continue to fill and continue to rip out the outer lining of the
Okay.
artery and continue to build, and next thing you know, you end up having this aneurysm all the way down here. So it's not gonna, the whole thing's not gonna like travel, but it can expand and get bigger and bigger and bigger and bigger. Okay? So you have a, let's see, do I have, yep, here's your aortic arch aneurysm, okay? So right where the blood comes out of the heart. This is one of the common ones. So it comes up, there's a lot of pressure built here, okay? And so all that happens is as the vessel so in your aorta, as it comes up and out, okay, what happens is it creates, based on history of high blood pressure, hypertension, atherosclerosis, it ends up wearing a hole in the inner wall, okay? And so then what happens is it starts to create an additional pocket out here, okay? So now your blood starts to move out here, okay? And so it starts to just basically just destroy the outer lining, and it continues to stretch, okay? And so it just keeps building a bigger and bigger and bigger pocket of blood up here, where most of that vessel is intact, but it starts basically just creating a giant hematoma on the outside of your aorta, right? And it's getting stretched farther and farther and farther the more blood that goes out there, right? So right now, we have some sort of leaking thing in this patient, right? Because we're not dead. Because where does the blood go when it pops?
Into the
thoracic
There's
cavity.
spacing.
It
So so if you look at the dimensions here, is that about half the blood supply that's supposed to be going out to the body? So just based on just like a smaller aneurysm like that, on the one on the far left, a small aneurysm like that takes half the blood supply away. So now, boom, we're down at half the blood pressure, right? Heart rate's going up because it's trying to do what?
Compensate.
Compensate, right? So as it's doing that, it just continues to go, and eventually what can happen?
Pop.
Yeah, so you're gonna get to the point where you are not gonna compensate any longer. Okay, and it's just gonna keep getting bigger and bigger and bigger. You're unable to perfuse, you don't have enough blood in the system, and either you're gonna die because of hypovolemia, because all this blood is stuck here in the cavity, and that's where it's like some people will live for short periods of time. They're like, hey, like when you get dispatched to a history of recent diagnosis of aortic aneurysm, you're like, oh geez, and they're complaining of back pain. You're like, oh geez. So the doctor thought they'd do okay for a while, but now they really haven't. So now we're to that point where it's like, okay, all of a sudden everybody ramps up a little bit and they're like, all right, this is the real deal. This person could be dead by the time we get there, or we gotta be ahead of it. Yeah.
Is that turbulent nonsense? Is that a risk of clotting?
Yes, so depending, because it doesn't have anywhere to go, right?
Right.
So it's just gonna go up here and it's just gonna continue to cool. And what it'll do is it'll eventually, it just keeps trying to stretch out the wall of the aorta, and it will just continue to fill, and as it stretches, it's just gonna keep moving and moving and moving. And it has the potential, because that's not moving all the time. It's basically like an eddy in the water. So it just comes up here, and it just starts pooling up, right? And the more pressure you get up there, the more stretching occurs. So the more pressure and more blood you get up there, that's where the pain starts to increase, pain gets worse, getting worse and worse, and that's where, hey, I got a history of this, I know it's there, but I'm calling you because the pain's getting worse.
They could go.
Bad,
Yes.
right?
Is there a water
Water balloon about to split.
Is there anything they can do in the hospital setting for an aneurysm?
Yeah, so what they do is they go in and they put a little sleeve in here, okay? Like almost like a little rubber tube. And this rubber tube, basically it'll hook in here, here we go. So they take this tube and they hook it in here. They don't want blood sneaking past it. And they run this tube so blood's coming in up through here. Where did it go? Oh, to my hand. So now I got my blood coming up here. This tube will run all the way up and they'll run past it. They'll run past that aneurysm. So now the blood will bypass it, past the aneurysm, and get the flow back to the body. Then they'll go in and make an attempt to repair it, remove it, drain it, and then they may have to go back and readjust where that tube is located.
Would they keep the tube in it after the repair?
Yeah, so that's what they do. It's like a tube, mesh tube that they have in there, that they keep it in there, because if they go in and they drain this, what is the inner wall of this aorta gonna be?
Weakly.
It's gonna be all stretched, weak, and weak and just poor condition, right? So they're gonna keep that in there to reinforce.
Why don't they do that right away when someone's diagnosed with an aneurysm?
Because some of them aren't bad. Some of them are just like, hey, you have this aneurysm, we're gonna keep an eye on it. Money, funding, time in the OR.
Risk versus benefit.
So, yep. And
Also,
what?
a lot of
Risk versus benefit.
Yeah, I mean, you're putting something into somebody's aorta.
You said that half your blood supply could be in there?
Yeah, I mean, because it's cutting off, like you're
So
cutting off on.
you're saying 4 liters could be in there, right?
Half of the supply
Half of the
that's
supply that's
supposed
supposed to be going to the body at times, so.
Okay,
So it doesn't continuously flow. I'm just saying, you look at the abdominal one down there. You could
Uh-huh.
get 2-3 liters down into an aneurysm in the abdomen. Aorta, it's gonna be a little bit harder just because you have all the vessels that are there already, and that's gonna kind of help with some of the restriction. But down in the abdomen, you can have a giant aneurysm there.
that holds a couple liters?
Yeah, easily a couple
And
liters.
so, that couple liters that it's holding, those are stuck there, not moving?
Yeah,
Because they're,
basically just, it's not perfusing, it's not circulating, it's not
Right.
doing anything. And so, as that continues to build, and it gets bigger and bigger, then you're gonna end up with your blowout, and that's when you get, so you can end up with a small leak, where it just, hey, it hasn't completely exploded, and you're losing a little bit of blood, right? And so those are gonna be kind of your anemic patients, that they're gonna be diagnosed with anemia, and then, hey, you got this leaking thing, it's like, those are not ones that they're gonna hang on to and say, hey, we're gonna wait this out. That's something that they're gonna go in and fix, because in the aortic, how high is the pressure in the aorta?
the highest it is anywhere else.
Right, so high pressure in the aorta, they wanna make sure they fix that stuff as soon as, because it's just gonna keep opening up bigger and bigger and bigger. All right, so let's take a quick break, get some drink, go back.